Femtosecond laser IOL explantation surgery. The authors have no financial interest.
What do you think? A brand new table. This, I don't like it. You will. Give it time. I mean, you will neurally adapt. I don't think so. Please, get rid of it. It's very hard to fit such a big table through that window. I'd have to break it into tiny pieces. Look, that's not my problem. Just get rid of it, get me a new table, and don't damage the room in the process, okay? Scalpel. Lightsaber.
Despite meticulous planning and successful implantation, IOLs may need to be explanted. Here is an image of an opacified plate haptic IOL. The lens opacified 3 years after implantation when the patient had retinal detachment surgery. This hydrophilic multifocal IOL is large and thick. It is therefore difficult to cut with scissors or fold in the anterior chamber. In our laboratory, we showed that this and other IOLs can be safely transected with femtosecond lasers. At low energy settings, no toxic gases or particulate residue was detected. We then determined the optimal setting for transection and separation of this hydrophilic IOL. We used the setting in this 59-year-old gentleman with an opacified IOL. His vision was 6/24. You will note the white capsular adhesion at the edge of the lens. Dispersive viscoelastic was injected under the anterior capsule to separate the IOL from the capsule. The amount of viscoelastic in the bag needs to be limited, as gas formation during femtosecond laser surgery will add further volume, which could result in capsular block syndrome. The main wound was sutured and the patient was docked under the lens ex gantry. A 5.8mm lensotomy cross and capsulotomy template was positioned over the IOL. This was intentionally displaced inferiorly so that at least the distal end of the optic was completely cut. The anterior capsulotomy was kept at the same diameter as the lensotomy length, so that in case the lensotomy came too far anterior, it would not cause an anterior capsular tear. The posterior capsule was faintly visible. The laser overlay was placed over the IOL to avoid the posterior capsule. Please note the lensotomy profile does not match that of the IOL, as it is designed for the crystalline lens. The ablation during the lensotomy at 8 microjoules energy level, 3 micron spot and 6 micron line separation was 45 seconds. The patient was returned to the operating theatre. More viscoelastic was injected into the bag to bring the optic out of the bag. An angle McPherson forceps was used to grasp the optic close to the centre of the IOL, and a Rosen chopper was introduced through the side port. Using counter-traction, the fragments were separated. The proximal portion of the optic was not cut because of the inferior displacement of the laser. This was cut using Van Ness scissors. The proximal haptic was brought into view and cut. The superior wound was enlarged to about 3 mm, with the added hope of reducing the with-the-rule astigmatism of 1.36 diopters. The lens was removed as a single piece. A one-piece hydrophobic lens was placed in the bag and the patient achieved 6/9 vision the day after surgery. At 3 months, there was no change in endothelial cell density or astigmatism. The image on the right shows the opacified IOL. The SEM shows the clean lasered edge with the yellow line marking the edge created by the Van Ness scissors. In a second case, the IOL subluxed following a complicated intravitreal gas injection to displace a macular bleed. The IOL was repositioned to the sulcus, an anterior vitrectomy was performed, and a Malyugin ring was inserted. The patient was docked under the laser, and a false anterior capsule was presented to the lens X. The IOL was lasered with the same settings as the previous case. The patient was taken back to the theatre, where the optic was again grasped midway before using the Rosen chopper to split the lens. A sulcus IOL was placed. The patient remained at hand movements vision due to the macular bleed. The endothelial cell density reduced from 1960 to 1600, possibly due to the more complicated and prolonged surgery. SEM shows that laser profile did not completely match the IOL profile, and therefore the cut was not deep enough to transect the posterior 15% of the IOL. However, this did not prevent us from separating the fragments. Tips and tricks. For both hydrophilic and hydrophobic acrylic IOLs, 8x3x6 laser setting is quite satisfactory. For in-the-bag transection, a dispersive viscoelastic is ideal. However, care must be taken not to overfill the bag. A capsulotomy of the same size as the lensotomy is useful in avoiding an inadvertent anterior capsular tear with the lensotomy ablation. Lastly, in order to separate the fragments, it is easiest if the middle of the IOL is grasped by the forceps before conducting the chopping maneuver. In conclusion, the benefits of femtosecond laser transection are the short laser ablation time and the ability to explant large lenses through small corneal incisions. These factors, we believe, enable quick recovery.
Happy? It's okay. Looks a bit like a lens though, doesn't it?